Okay, so I was saying I'm very pleased to be here and delighted to see so many people in the audience. As Pierre mentioned, he invited me here at least 15 years ago to give a presentation for a meeting with the Minister of Health. And my recollection was this was a 2-day meeting and I had a very bad cold. So I came and gave my presentation and then I went and fell asleep for a day. When I gave my presentation, we were talking about what you'd need to do to improve quality of care and do other things, and there's a lot of focus on what individual hospitals or groups could do. And when I came back at the end of the second day, we were going to establish a big national institute to do this. And I had no idea what happened in the middle, but it seemed like a very big leap from the first day to the second day. But I'm very delighted to be here again, so thank you very much. What I want to do is really talk about initiatives to enhance evidence-informed practice and policy. So trying to make sure, what do we know about trying to make sure that the care that patients get when they're with healthcare professionals is informed by rigorous evidence? And at the other end, what do we need to do to ensure that healthcare policy is informed by evidence whilst it's being formulated? So I really want to talk about what evidence should inform policy and practice, and also what should healthcare stakeholders and systems do to facilitate evidence-informed policy and practice. I then want to talk a little bit about the Cochrane Effective Practice and Organisation of Care Group, and talk about our progress to date, and also some of the resources we're producing to support practice and policy. Sashi will talk through an EPOC example in much greater detail, so this is really a fairly high-level view. And the background to this is that societies value health, and they value health research and expect that health research is going to pay back by improving the quality of lives and outcomes of patients. So clinical health services and population health research constantly produce new research findings. But the findings of this research will not change population outcomes unless healthcare professionals and healthcare systems adopt them. And the unfortunate thing is that there is consistent evidence from around the world that patients do not get the care that healthcare professionals or healthcare systems would aspire to. Repeated studies have demonstrated that between 30 to 40% of patients do not get treatments of proven effectiveness, and around 20 to 25% of patients may get care that's either not needed or is potentially harmful. And these studies have been conducted in truly across the world: UK, Canada, Australia, US, South Africa, China. This is a fairly consistent finding. And for me, it highlights the idea that this is a difficult problem. No healthcare system has got it right. This is going to be an ongoing challenge that, that we're going to face. There's also, I think, consistent evidence of poor research use during policy formulation and implementation. And as I'm talking, I'm going to use a lot of the work of John Lavis, who's a colleague of mine based in Hamilton at McMaster. But one of his studies, he looked at 8 Canadian health policy-making processes and just looked to see whether there's any documentation that research evidence had been considered during that policy-making process. And no research was cited in 4 out of the 8 policies. They may have demonstrated, they may have considered research, or it could have been and not reported it, or they may just not have even thought about going out and looking at the research. And there's only one policy-making process where it looked as though evidence had informed every stage of the process. And so it raises concerns that if we're generating this knowledge, why is it not being better used both in practice and policy? When we talk about evidence-informed policy, I think it's important we talk about evidence-informed rather than evidence-based policy, because one of the issues is there are many things that inform policy, not just the research evidence. But I would like to make sure the research evidence is very explicitly considered in policy formulation, even if the end policy doesn't look very evidence-based, as long as they can say we considered different bits of evidence. Okay, that wasn't me. some of the issues when you look at evidence-based or barriers to evidence-based policy, the common criticism of research by policymakers is there's no relevant research. I want to know about how to plan my human resources for the next 20 years in this country. There's really very little research relevant to me. The research might be difficult to access. I don't work in an academic institution, so I just don't have even, can't even think about how to access information. And the research might be difficult to understand. Most healthcare professionals have a scientific background, but many policy makers and policy analysts may come from the humanities, the political sciences. Why would we expect that they'd be able to handle scientific evidence? And so I think there are kind of quite deep-rooted issues that we need to deal with. So this increased evidence over a 20 or plus year period that we're not using evidence optimally has, I think, led to broader policy interest in innovative strategies to promote evidence-informed practice and policy. At one level, we shouldn't continue to invest in biomedical and health research if we're not making sure that as that research comes out, healthcare systems use it and our patients benefit from it. But Richard Groll in 1997 pointed out that most of our approaches to changing clinical practice and health policy were often based on beliefs rather than scientific evidence. So if we know that we've got poor DVT prophylaxis rates in our hospital, maybe people sit around and say, how are we going to improve this? They very rarely say, do we have any evidence about interventions that have tried to improve DVT prophylaxis elsewhere that we can learn from as we're doing this? And Richard Groll made this great quote: evidence-based medicine should be complemented by evidence-based implementation. In other words, as we're thinking about how we support use of evidence by healthcare professionals or policymakers, we should look to see if there's evidence to help us understand how to do that better. So in terms of the, you'll see as I go through my talk, I'll have some slides which talk about improving practice, and so that's really talking about improving use of evidence by healthcare professionals when patients are with them, and improving policy. So I'm kind of splitting them out and having them as parallel streams. If we think about trying to improve practice, this is a useful, I think, framework that's been developed by a Canadian colleague, Ian Graham, that looked at 31 different planned change processes and identified commonalities across them, and started to identify a new model that built upon all these different processes. And the argument here is that this is a way of thinking about a problem that if you follow it, you're more likely to be successful than not. And what you have is you have a central inverted funnel, and this is known as a knowledge creation funnel. And the base of the inverted funnel is talking about primary studies, the kind of studies that we do as researchers. The next section is looking at knowledge synthesis, so systematic reviews. And the final one is looking at knowledge, tools, and translations. Knowledge, tools, and products. And the idea here is really, if we're thinking about activities to improve practice, we should be focusing not on primary studies, but rather on systematic reviews or knowledge, tools, and products. So that as the evidence comes from primary studies and is synthesized, and then you develop guidelines or other tools, it becomes more relevant and more easy to access by the different healthcare professionals. So the key issues here are that individual studies rarely by themselves provide sufficient evidence to change policy or practice. Individual studies are often misleading. An additional issue is dealing with the hype, and that often research findings are over-publicized. And so the results of individual studies need to be interpreted alongside the totality of evidence, in other words, systematic reviews or guidelines, patient decision aids, other types of approaches. Okay? So that's really talking about what's the evidence that we should be trying to inject into practice. You then have on the outer circle the action cycle, and some of the key steps here are that if we're trying to think about what strategies to use to change clinician behavior, we need to assess the barriers to knowledge use. So we need to understand what is getting in the way from healthcare professionals to use the knowledge that we suggest. And the challenge is that there are many different barriers that prevent people from acting upon knowledge. Maybe one of the differences from 20 years ago is that the problems were often at that time thought to be about clinician knowledge. And all we had to do is educate people better, and all the quality problems would go away. But what we recognize now is that there's actually a lot of other sort of barriers in the system, and I'll just walk through some of those. So there could be barriers at the structural level. In the 1990s, I did some work with Qasim Mohammed, who was the professor of obstetrics in Harare University in Zimbabwe. He had been one of the trialists in a large trial that demonstrated without doubt that magnesium sulfate was the treatment of choice for preeclampsia. That's a hypertension-related illness in pregnancy that if, for eclampsia, that can lead to both maternal death or baby death. So he had been an author on a paper in The Lancet that said magnesium sulfate is a treatment we should use. 3 years after the publication, he could not prescribe that drug in his hospital. And the reason was, at that point in time, the Zimbabwean government largely bought drugs based upon the WHO Essential Drugs List, and the WHO Essential Drugs List had not been updated. So this wasn't a knowledge issue. This was a coverage decision made, not even in the country, at a global level. Sometime after that, the WHO did change their Essential Drugs List, and magnesium sulfate was put onto the Essential Drugs List. Zimbabwe potentially tried to purchase it, and it then highlighted an awful lot of other problems in Zimbabwe about the drug production, drug chain. But initially, the sort of major challenge was just at the level of the sort of the national or international structures. There can be barriers at the organizational level. People may not have the right staff or the right facilities or equipment. My example here would be that if you look at any diabetes guideline or dyslipidemia guideline, one of the first recommendations you'll come across is that you should optimize people's diets. But certainly, and most patients with diabetes or dyslipidemia are being managed in primary care settings, and certainly in the UK, there's empirical evidence that family doctors and nurses working in primary care are often not well equipped or trained in terms of how we provide dietary advice to patients with these conditions. And the UK doesn't have enough community dietitians, and so even though that's the first level A recommendation in any guideline, it's a skill mix issue that's going to get in the way for that. In terms of things like lack of facilities or equipment, in stroke care, one of the big breakthroughs in the last decade has been the idea of using thrombolysis or clot-busting drugs for patients with ischemic strokes, I think. I can't remember which kind of stroke. The issue here is that patients need to be scanned within 3 hours of the onset of their symptoms. If you are living more than maybe half an hour to an hour from a centre without a scanner, with a scanner, then I think it's impossible for patients to be considered for thrombolysis of stroke. Because if I'm living somewhere where it's going to take me an hour to get to the centre, even if on the first second I had my stroke, that I recognised that and got an ambulance to take me, I'd probably never get there, or the system wouldn't be in place for me. This is an area where the barrier may not be surmountable, because often we're going to have rural areas where we just can't put scanners in. But in that case, we're going to have to recognise that and think about how else we can provide care for those patients. There can be barriers at the peer group level. So the issue here is that human beings are social organisms. And when we work together over time, we develop a shared set of beliefs, a shared set of ways of doing things here. And when I was a GP trainee, and I'd go from one hospital ward to another hospital ward, they'd do things completely differently. And no one ever said, well, this is because we're evidence-based and they weren't evidence-based. It's just maybe something happened in that ward 10 years ago, or someone said something and they started down that route, and something different happened in this ward and they started down that route. And the issue here is it's very hard for an individual to change their behavior if their peers around them don't think they should do that. So there's a lot of social pressure. And so sometimes we have to think about challenging the opinions at the group level as well as the individual level. There can be barriers at the individual level relating to our knowledge, our attitudes or skills. But we've now found consistently across a large range of studies that often for non-emergent knowledge, there are still problems in the healthcare system, that healthcare professionals have enough knowledge. Yeah, in Canada, 40% of patients with diabetes do not get their eyes regularly screened. But the family doctors know that diabetics should get their eyes screened. They intend to counsel them, and it's other things that happen in the system that stop them from doing that. So increasingly, I would argue, it's not particularly a knowledge issue we're trying to address, but rather the issue about how we allow people to act upon the knowledge that they've got to improve the quality of care. The final barrier is at the professional-patient interaction. And the issue here is that human beings are imperfect information processors. We are not supercomputers. We are sort of have relatively limited processing capacity. So one of the things we do as human beings is we try not to think. Okay? Now that may sound a bit odd, because certainly when I was trained as a physician, my sense was that I was a very reflected person and I had to think. But the reality is that we, as human beings, the way we get through the day is we start to develop automatic or habitual behaviors. So if a patient comes in and says they've got a sore throat, I'll just do this. I won't think about it. I just do it. Okay? Because if I had to think about everything I was doing, I'd see 3 patients a day, and I have to have at least 40 people, and I have to eat at some point in time. So we get into habitual behaviors. We also have scripts that we use, which is how we communicate. And they're things that have we found work for the majority of patients. So I haven't seen a patient for 15 years, and I can tell you what my script was about why you didn't need an antibiotic for sore throat. And what would happen is once I'd got to that stage in the consultation, I'd just turn it on, and I could think about other things. What else do I have to do with this patient? I'm running half an hour late. How am I going to catch up? Who's going to pick the kids up? Yeah, I didn't have to use the thinking part of my brain when I was talking. The challenge here, the reason we do this is because they work the vast majority of the time, and they work well. But it's really hard to change those habits or those ways of talking. Because as soon as you're trying to change your script in real time, you start going, the reason you don't need an antibiotic is, and that doesn't instill confidence in the patients that you're looking at. So we don't like to have to do that, and it's really hard. So the reality is there are many different barriers to people using research evidence in clinical practice. And I think if we want to think about how we support people to use evidence, we have to sort of try and understand which of the most important barriers are at any one point in time, and also how can we best address those. And don't assume there's going to be a simple solution, but rather we have to tailor it. Another important step in the knowledge to action cycle is about choosing interventions. So having made a diagnosis of the barriers, what are the treatments that will lead to improved care? And this should be based upon a number of things, a diagnostic assessment of the barriers. We also need to think about what the mechanisms of actions of our interventions are. And then what we know about the effects of the interventions from evidence, and then real practical issues. Quite often people have their favorite tool. They have their favorite intervention. So someone might always want to use computerized decision support as a potential solution, or academic detailing. This would be a bit like getting a handyman to come to your house who's got a hammer and then thinks that everything he has to do is going to be fixed by hitting something. Okay, so if you have a hammer, everything looks like a nail. So you go around just hitting it. Yeah, and if you find a nail, it'll work. But yeah, if you're trying to get a screw in, then it's not going to be as useful. And so we need to think about sort of basically what's our toolkit, and think about which tools are going to work depending on the problem that we have. If we're talking about evidence-informed policy, we don't really have, I think, a stronger evidence base there. But here's something that, here's a framework that's been developed by John Lavis, Andy Oxman, and colleagues. And it's published in the Health Research Policy and Systems Journal, which is an open access journal. But it's basically a series of 18 papers that, again, will guide people through a series of processes and ways of thinking about how you might incorporate evidence into the policy-making process. So, what we've talked about so far, I think, are the idea that we should aspire to use evidence in our decision-making. That we should, in a clinical world, think about sort of systematic reviews about the clinical content of evidence. We should assess barriers. We should select interventions based on that. In a policy world, the arguments are very similar. So John Lavis would argue that there are similar reasons for suggesting that policymakers should be using systematic reviews as their unit of knowledge when they're thinking about using evidence within a policymaking process. And the reason that he articulates is that systematic reviews reduce the likelihood that decision makers will be misled by research because it's more systematic and transparent in the identification, selection, appraisal or synthesis of studies. In general, a good systematic review should just be more trustworthy. It can increase confidence among decision makers about what can be expected from the intervention by increasing the number of observations. I think policymakers will often have researchers coming and saying, I've done this piece of work and you should change your policy as a result of this. And the policymaker has no idea whether this was a well-conducted piece of work, whether the rest of the research evidence in the world supports that. So a systematic review, by bringing together all the evidence in the world, actually allows a policymaker to say, is there a consistent finding across all different settings and contexts? Are there different effects? In which case, which is most likely to be, which is most similar to my setting? It also allows potentially decision makers to focus on appraising the applicability of systematic reviews rather than having to find and synthesize studies themselves. So if someone in the Ministry of Health in France wanted to do, look at the effects of hospital at home on palliative care, which is I think the example Sasha is going to use, they could say, I'm going to take 6 to 12 months to do the review myself, or if Sasha's actually done the review already, they could pick that up and say, I can actually spend my time thinking about what this means for us in France. And so the value of having a systematic review is someone's done a lot of the hard work, which is technical, and it allows the policymakers to do the judgmental work, which is local, contextualized, and where they're best skilled. And the final thing is that it actually allows public debate about what the evidence means. So by having a systematic review that you can put out there, that everyone can look at, it means that we don't argue about what the evidence is, but we might argue about what it means. So again, in the policy-making world, it's not unusual for one pressure group to say, we have one study that shows that, I don't know, fluoride in the water does terrible things to you, and another group that says, we've got evidence that fluoride in water does nothing, and they're different studies. By bringing all the studies together, it actually allows people to say, we're not going to argue about what the evidence is, but we may still argue about what the evidence means. And so John would argue that these are conceptually similar arguments about why we would look at systematic reviews for clinical evidence that are as applicable in a policy world. Here's some more information about bias to evidence-informed decision-making. And this just highlights the sort of level of evidence that we have in the policy world. So Simon Invar and colleagues in 2002, this has been updated a couple of times. But I've not updated the slide because the conclusions don't change. But they basically looked at over 24 studies involving 2,000 interviews with health policy makers. They focused on hypothetical scenarios or retrospective perceptions of the use of evidence in relation to specific questions. So this was a range of studies that they'd go and either show people evidence and say what would influence whether you use this or not, or maybe remember the last policy you made, did you use evidence, what made that more or less likely? And they found that things like personal contact with researchers seemed to facilitate use of evidence, the timeliness and relevance of the evidence facilitated that, summaries with policy recommendations rather than 300-page project reports helped, and barriers were almost the inverse, that the lack of contact, the lack of timeliness or relevant research, mutual mistrust or power and budget struggles get in the way. So again, quite a lot of these are not necessarily about knowledge-based issues, but they're about sort of basically supporting people with the right knowledge at the right time. So this brings us to EPOC. And what we hope we do is start to provide some of the evidence that will be helpful for these different decision makers. So EPOC undertakes systematic reviews of interventions to improve healthcare delivery and healthcare systems. And we include professional interventions, so what are the best ways of providing CME, audience feedback interventions, also financial interventions, what happens if we change the way we reimburse healthcare professionals or ask patients to make co-pays, organizational interventions, what happens if we change who delivers care or where care is delivered, and finally regulatory interventions, what happens if we change the law. We were established in 1994. So I've been the coordinating editor since 1997. I'm delighted that Sasha Shepherd in the last 12 months has become my co-coordinating editor. The editorial base is based in Ottawa in Canada, and we have 4 satellites in Melbourne, Australia, Oslo, Norway, Oxford, UK, and now Paris, France with Pierre. We have 12 editors, general editors who actually handle the review process, 6 specialized editors focusing on things like statistics, economics, policy liaison, and we're currently working with about 550 authors from over 33 countries. The progress to date, over a now sort of 16, 17-year period, we've completed 87 reviews, and we have a 44 ongoing. I'm not sure if that sounds like a lot or a little. I mean, one of the things to say is that these reviews are incredibly challenging to do, and I promise you that 87 is quite a lot and quite good productivity. As examples, in terms of the professional interventions, we have reviews of things like audit feedback and whether that influences professional practice, the effects of on-screen point-of-care computer reminders. And Pierre and I think Bernard also have done a review on computer-assisted drug dosage. For organizational interventions, the effectiveness of strategies to change organizational culture to improve healthcare performance, lay health workers in primary and community healthcare for treatment of certain conditions. Financial, what's the impact of user fees on access to health services in low and middle income countries? What are the effects of capitation, salary or fee for service and mixed systems of payment on primary care? And finally, regulation, what happens if we change pre-licensure education for health workers on health worker supply? And pharmaceutical policies, what happens if we use caps or co-payments? So you can see we cover a very broad area, but hopefully areas that will help address those high-level decision makers thinking about how do we improve quality of care, how do we improve policies that we make. One of the things that EPOC has done is develop a taxonomy of interventions. And we did that largely to help structure the work we've done. So we wanted to sort of basically identify all the key interventions and how we're going to cover them off. This is just a part of our taxonomy, focusing on the professional area of our work. So things like educational meetings, local opinion leaders, audit feedback. We've got reviews or planning reviews in all of those areas. Oh, I've won something. I've won an iPad too. I think I have to go somewhere. I don't know where. Okay. Oh. I don't like. No. Oh God. I need somebody. Right. Thank you. Some of us are getting too old for technology. What I want to do in the next 5 minutes is just highlight the kind of evidence we have around the bolded interventions, so education materials rather, and educational outreach. So by educational meetings, we mean the distribution of published or printed recommendations for clinical care that could include guidelines, audiovisual materials, electronic publications that are either delivered personally or through mass mailings. So these are things, what happens if you publish your article in your scientific paper in JAMA, or what happens when the French government disseminates guidelines for practice across the country. In terms of what are the kind of mechanisms of action, I would argue that these largely target knowledge at the individual healthcare professional peer group level. So that if you need to sort of change processes of care, this may not be very useful, but it can particularly target knowledge issues. The nice thing about these interventions is they're relatively low cost and they're feasible. Something we use most commonly across healthcare systems, just sending information out. In general, or certainly up until probably about 10 years ago, you'd have seen lots of systematic reviews saying this doesn't work. We actually have a high-quality Cochrane review done by Anna Farmer. I was a co-author on this in 2008. By that time, she found 21 studies, including randomized controlled trials and quasi-experiments. And across the range of studies, it looked as though a distribution of educational materials led to improvements in care. So it did actually look as though there was, in general, a small improvement of care by just sending information out. And across the 6 randomized controlled trials, there's about a 5% absolute improvement in care. So in other words, if care was 50% compliant with guidelines before sending these materials out, they got up to about 55% after. Okay? So this is something that if I was in the healthcare system, I might consider, because it's cheap, low cost, and even if you get very small improvements in care, it may well be worthwhile. Educational outreach is also known as academic detailing, and this is the use of a trained person to meet with providers in their practice setting to give them information with the intent of changing their practice. So the idea behind this is first developed by people like Jerry Vaughan and Steve Sumrai in Boston, and it was using the detailing approaches of the pharmaceutical industry to send people in who are going to give more evidence-based messages out. And in terms of the mechanisms of action, this tends to derive from social marketing approach. You're largely using social persuasion methods to target either someone's knowledge or attitudes. And in most academic detailing settings, the aim is to get across 3 messages within a 10 to 15 minute a session using an approach tailored to individual healthcare providers. So one of the things that both the pharmaceutical company and academic detailers do is they try and get a sense about what flavor of healthcare professional you are. And this is where I sort of insult a few people in the room. So what they recognize is that Philippe Bravo is the evidence wonk. So if we want to try and influence him, I need to take him a New England Journal of Medicine paper that demonstrates what we want to change his practice. Because he'll say, show me the evidence. He won't allow you just to sort of try and persuade him and schmooze him. Bernard Bernand is wants to sort of basically be aligned with his peer group, with other people around him. And so what the academic detailer will say to Bernard is, you may have, I don't know if you talked to your colleagues about this, but you may find that actually a lot of them are now starting to use this drug, and you might think about the specialist in the hospital was initially very suspicious about this, really didn't like it, but used it once or twice, and now you probably find most of his patients are coming out with this drug. And we're trying to sort of basically use a social influence to say to Bernard, who wants to be nice and like all of his other colleagues, that he should follow that. Pierre Durier, find a way of taking him to a rugby match, he'll prescribe anything. So the idea is that you have different scripts in your head, and you very quickly work out what flavor people are at. They'll often use additional strategies to reinforce the approach. So I've not seen a patient for 15 years. My wife doesn't see patients. We still end up with pharmaceutical marketing things in our house. We think there are pharmaceutical marketing fairies that come down the chimney every night and leave pens and mugs and other things. But if most of you are in a clinical environment, I'd be very surprised if you aren't multiple times a day having just these reminders. They're endemic. And they also typically focus on relatively simple behaviors in the control of the individual physician. So if you think about detailing by the drug companies, they don't ask you to change how you diagnose a patient, how you manage a patient. They say, don't use that old drug that's got lots of side effects. Use this new one that's got no side effects, honestly. And so it's largely about just changing what's happening in the individual clinician head. It wouldn't help if you needed to make more broader system changes. And I remember speaking to someone who was very senior in a drug company in Spain who said when ACE inhibitors for heart failure came out, that you could not get that across with academic detail or with detailing because it fundamentally asks family physicians to change their model and their concept about how they're going to manage heart failure and require them to get more investigations. And so academic detailing just was not going to work then. One of the issues around detailing is it's relatively expensive. You need to pay somebody to go out and visit healthcare professionals. You need to pay so people are going to be credible, so they have to be smart and trained. So it's relatively expensive, but it could still be efficient, and it's going to be less effective for complex behaviors requiring a team or system change. There's a high-quality Cochrane review. There are 69 randomized controlled trials of academic detailing. In general, it works. If you're looking at changing prescribing behaviors across 17 randomized controlled trial comparisons, you had a median effect of 4.8% with an interquartile range of 3 to 6.5%. That may not sound a lot, but given the cost of drugs, that is still likely to be cost-saving for a healthcare system under most circumstances, and similar effects for other behaviors. And this is just to give you an idea of both the volume of evidence out there and also the kind of effects we're seeing. So Noah Evers has updated our audit and feedback review. It's now 140 trials of audit and feedback. It works. You get about a 5% improvement with an unquartile range from about +1 to 11%. This challenges to change the way we do research in the future because we actually want to understand how we optimize audit and feedback, not test whether it works compared to control. 81 trials of educational meetings. It works. Financial incentives, there's only 3 randomized controlled trials out there at this point in time. If you're interested in hand hygiene, when we come to talk about safety, there's only 1 randomized controlled trial, and there's less than a handful of well-conducted quasi-experimental studies. So in some areas we have a huge amount of knowledge. In other areas we don't have very much knowledge at all, and we should be trying to focus upon doing robust evidence in those settings. What about the policy-making world? My friend John Lavis says, I have it easy. We have 140 trials of audit and feedback. If you actually want to look at the empirical or the experimental evidence of how to change policy, this is not an EPOC review, but a review done by Canadian colleagues, you find there's not very much information out there. So Craig Mitton and colleagues try to basically look for interventions to try and promote use of evidence in policy. They found 81 studies. 70% of them were published between 2003 and 2005, which suggests it's a very rapidly evolving area, but there wasn't much done before maybe 2003. 55% of them were in Canada. We seem to have some sort of interest of this in Canada. 23% in Europe, 11% in the US. Most of them were not evaluating implementation of different strategies. Most of them were discussion documents, reviews, surveys of relevant stakeholders, but not really talking about what's the effects of trying to use these interventions. There were 18 studies that did look at implementation processes to try and improve use of evidence by policymakers, but they were generally weak and difficult to draw robust conclusions. And this was a conclusion Craig made. The review examined and summarized the current evidence base. It found that about 20% of studies reported a real-world application of a strategy, and few had been formally evaluated. At this time, there's an inadequate evidence base for doing evidence-based KTE for health policy decision-making, and we actually have to do a better job. So compared to the clinical world, we have a much weaker body of evidence about how we influence policy. One of the good things is there's a huge amount of thought and innovation happening in healthcare systems about how to do this, pushing more targeted messages out to policymakers, using knowledge brokers, building partnerships between researchers and policymakers, building capacity to use evidence in policymaking settings. But at this point in time, we have very little evidence to say which of these should we actually encourage people to use. So one of the arguments would be innovative, do what you think, but evaluate it so we can learn from it. Final few slides are just highlighting that there's a growth of resources to help people if they're thinking about trying to improve evidence use in knowledge and practice and policy. The first one I have to put up is the Cochrane Library. So we claim the Cochrane Library is an amazing resource with high quality systematic reviews and other evidence-informed or other evidence support systems within that. One of the challenges with this, though, is that if you're a policymaker or a clinician coming to look for a particular issue, you have to wade through quite a lot of that, particularly if you're a policymaker, because there are many, many more clinical reviews than there are policy-relevant reviews. And so what we've started to do is find other ways of presenting that information to policymakers. This is a project that EPOC has done with the Health Technology Assessment Agency in Canada, where we've actually gone out and identified over 300 systematic reviews of professional behavior change interventions. We've appraised them, we've summarized them, and they're all in a searchable database. So that if you are working in a quality improvement agency and you want to know how to, or what would be the effects of audit and feedback, if you went here, it would have actually identified all of the reviews for you, summarized them, told you which are high quality, which are most up to date, and it means that you can largely, hopefully, access information most quickly. In the same way, John Lavis has produced health systems evidence. This has been done with both EPOC and Cochrane Canada support, but he was trying to address those questions. If there's no research evidence, I can't find it, and I can't make use of it. So he's identified over 2,000 systematic reviews, policy briefs, or other policy documents relevant to high-level governance, finance, organisation, or implementation issues, really seeing for senior managers in the healthcare systems or in government. And you can search through that to identify reviews in those areas. And finally, just to come back to the support document as being a major resource for people thinking about what are the kind of processes, what are the skills you need to do if you want to make better use of evidence in the policy-making field. So, in summary, there's a substantial evidence base of continued failure to optimally use research to inform policy and practice. That systematic reviews provide the best evidence to guide practice and policy, and systematic reviews also provide the best evidence to guide decisions about what strategies that healthcare system stakeholders should use to facilitate the use of evidence. EPOC undertakes systematic reviews of interventions to improve healthcare delivery and healthcare systems, and there's a substantial evidence base about how we change the behaviours of healthcare professionals, much less if we think about how do we improve policy formulation processes. But that is evolving and getting better. And there's also increasing availability of resources to facilitate decisions about initiatives to enhance informed practice and policy initiatives. A couple of years ago, I was asked to talk at the 20th anniversary of the Health Systems Research Unit in Aberdeen to say what have we learnt in this field. And at one level, I kind of feel like we've not moved forward much. But actually, when you look at where we were maybe sort of 10, 15, 20 years ago, where I think we had a much more naive view of the world and of the problem, we've moved hugely. We have a large evidence base that we can lever. We now need to be a lot more sort of, I think, thoughtful about how we do science to improve that evidence base. But also we need to think about how do we ensure that decision makers in healthcare systems access and use that evidence base to the benefit of patients in the system. So that's my email. That's the EPOC URL. And the URLs for the RX for Change, Health Systems Evidence and Support. And I'm sure Pierre will make these slides available after the talk. Thank you very much.